Hello, I'm Scott DeRossi, Editor-in-Chief, Publisher, and Senior Advisor for MedMark Media. Welcome to an educational presentation and Q&A focused on screening for sleep-breathing disorders in the dental office with Dr. Mayoor Patel. Before we get started, I'd like to remind everyone to use the Q&A feature in the control pane and to ask any questions as they come about. They will be answered at the end of the session, however, as time permits. After the webinar, we will email all registrants both the recording and the instructions on how to access the free CE quiz to receive your certificate. Now I'm pleased to introduce our speaker. My friend and colleague, Dr. Mayoor Patel, received his dental degree from the University of Tennessee in 1994. After graduation, he completed a one-year residency in advanced education in general dentistry. In 2011, he completed a master's in science from Tufts University in craniofacial pain and dental sleep medicine. Dr. Patel is board certified in orofacial pain and dental sleep medicine. He presently is a co-founder of the British Academy of Dental Sleep Medicine, Ben Pat Institute, and a visiting faculty at Tufts University. He also served on the American Academy of Craniofacial Pain as secretary, a board member of the British Society of Dental Sleep Medicine, and as a board member and examination chair for the American Board of Craniofacial Pain and Craniofacial Dental Sleep Medicine. Thank you so much for joining us, Dr. Patel. Now I'll turn it over to you to learn more about today's topic.
Thank you, Dr. DeRossi. I appreciate the opportunity. So in dentistry, we have our waves, and the wave, I suppose, that we are going towards now is dental sleep medicine. It seems to be like the new buzz topic when it comes to things to implement. And in all fairness, I think we're in a good position to at least be part of the medical team when it comes to providing a service related to a dental treatment option to help these patients. My goal today will be to try and just get you teed up to understand what some of the clinical signs and symptoms might be that you see day in and day out, and how this might mean that the patient in your chair may be suffering from some form of a sleep breathing disorder. I'll use the term sleep breathing disorder because we don't know what they have until a diagnostic test has been performed by our medical colleagues. And I'll talk a little bit about how this process actually works. So to get started, like anything else in our careers, what one knows, one sees. What we were taught in school is what we more levitate to as far as treatment options, treatment plan presentations, and services we render. My job today is to kind of change that a little bit. What one does not see, one does not, what one does not know, one does not see. And where I'm going with this is you see things clinically every day. However, I'm going to try and just open up your eyes and try and maybe ask a question. Could it be that the reason this patient is presenting with some of these signs is related to a sleep breathing disorder? And I'll highlight the key areas that kind of come into play. And the epiphany will be that you see this every day, but probably did not realize this. Now, there's not much thing new from a survey standpoint. There's a few things coming up very soon, but as of today's recording, August 2025, dentists are not in a good position to recognize the risks associated with sleep apnea, let alone manage this condition. All right, so we know that there's a bit pitfall. I will say dental schools are actually making a tremendous stride in implementing this at the level that when these dentists graduate, they'll have some form of understanding as far as screening for these patients, working with medical colleagues. And in some instances, in some institutions, they actually have rotation clinics where they actually can fit oral appliances for managing sleep apnea patients. The key is it's getting better. All right, so this is the best thing that we could probably say moving forward. So just to kind of get you up to speed, let's talk about what normal airway looks like, and let's talk about what an apneic or an obstructed airway looks like. So when we look at a normal airway, the image to your left, you want to be able to breathe through your nose, and you should have adequate space in the nasopharyngeal and oropharyngeal space where air can passage through without causing any vibratory effects, therefore not having any snoring, and the person be able to sustain good oxygenation. All right. On the flip side, when we look at obstructive apnea, obstructive breathing, what we're looking at is a situation where you may have some pitfall where air does pass through the nose, all right? But as a response to it, there may be some form of constriction in the nasal passages and or the oropharyngeal tissues, quite frequently the tongue. And as you can see in this image, when there's some form of blockage that takes place, air does not pass through. And if this happens for about 10 seconds, we call this an apneic event, right? And there's different definitions to describe what apnea is and what hypopnea is. And we won't have too much time to elaborate on it, but I want you to understand that for someone to have apnea, they have to stop breathing for at least 10 seconds for you to be able to quantify it. There are some other parameters that one needs to meet independent of not breathing for 10 seconds, but just to get you the sense of the magnitude of how this process actually is. Now, if we look at prevalence, and we're using data from the US, and we're looking at some of the big cohort studies that were done between the ages of 30 to 55, you'll find that 24% of men and 9% of females actually have signs of obstructive sleep apnea, right? So it's quite prevalent. The problem with this is they have signs of it. If we get them tested, they will definitely test positive. But if you ask them, do you have symptoms? The only drawback is 4% of men and 2% of females will have some form of symptom that would probably quantify that they have obstructive sleep apnea or there's some form of sleep breathing disorder, and that is fatigue, or what is also known as daytime hypersomnolence, where they're extremely tired throughout the day. So if I took that into consideration, and that's the only question I asked, I'm only catching a very small subset where the vast majority of these patients that have this condition may not complain of being tired. And this is a very important question to lead with, because when you screen your patients, I don't want you to use fatigue as the only metric to try and identify these patients. We're going to look at clinical risk factors, which is what this presentation is all about, to try and identify these patients to get them treated, all right? Or get them at least diagnosed, then lead to some form of treatment. So what are some of the signs and symptoms that patients may present with? Well, one could purely just be snoring, all right? But more importantly, if a bed partner witnesses them gasping or choking, that's like a red flag. That's definitely go get a study done. You're more than likely going to test positive, right? So if there's gasping or choking in sleep, definitely a cardinal symptom that they're more than likely going to present with some form of sleep breathing disorder. Other symptoms can be excessive daytime sleepiness, fatigue, lethargy, but as I pointed out a slide before, only a small subset, 4% men, 2% of females, will say they have these symptoms. And then other things they might be, they may present themselves with is unrefreshed sleep, the sense that they went to bed for 6 to 8 hours, but sure didn't feel like they slept for 6 to 8 hours, right? So we call that sleep disruptions or fragmented sleep, where they don't get the ability or the opportunity to get to deeper sleep and hence therefore wake up feeling tired or unrefreshed. And what's interesting as well is depression can be a symptom associated with patients that have apnea. Now, when you look at males in general, males have an interesting characteristic. They will basically have symptoms leaning more towards snoring, or someone's observed that they actually have apnea and they are very tired or they're sleepy, right? You present with these symptoms, you're more than likely going to test positive for apnea. Where it gets tricky is our female patients. Our female patients present a little bit differently. They'll present with symptoms that are more suggestive of depression and morning headaches. Now, I need you to think this through, because if it's depression-like symptoms, some of your female patients that are in your hygiene chair, for instance, may have true depression. But some may present with depression as a result of having fragmented sleep because they're not having quality sleep. If they fragment their sleep, it's almost like sleep deprivation. If you have sleep deprivation, a good example is when you have moms that give birth to children, the first several months, their sleep is so fragmented that they do present with signs of depression, right? But to tie into that, morning headaches can be a sign or symptom for these patients. The problem with that morning headache statement is, as a dentist, if our patients say, hey, doc, I wake up with morning headaches, our intuition will lead more towards, I think you're parafunctional at night, you need a bite guard or a night guard of some form. And this could be misleading, as you'll see once again in a short bit, that bite guards do have a place, but sometimes they may have a negative consequence in some of these patient populations. So just recall that men may come in with snoring and someone that's observed apnea and tiredness, fatigueness, whereas females may come in with signs and symptoms that may lean more towards depressive symptoms and or have morning headaches. So what are some of the most common risk factors for these patients? Well, risk factors are split into two classes: modifiable risk factors and things that you can't really modify. So modifiable risk factors is obesity. We do know by far You put on weight, you're going to have a high incidence of apnea. If you're apneic and you're overweight and you lose the weight, you're going to actually improve your apnea. So we do know obesity can go bi-directional when it comes to that. We know some medications can induce apnea, such as drug opioids that reduce the respiratory drive, benzodiazepines. Then what's not included, but I think you should be very mindful of, is also medications in the class of muscle relaxants, right? If tongue's a muscle and it's a skeletal muscle and using muscle relaxants to help with, say, myofascial pain or neck pain or back pain, it's not selected to any specific muscle group. It's going to also affect your tongue. So that can probably play a role as far as being a modifiable factor, where maybe change the prescription or find another way of addressing the symptoms to try and get them off some of these meds. Alcohol intake, smoking, supine sleeping position, nasal congestion, and/or obstruction can definitely play a big role here. Once again, these are things that one can change. Drinking alcohol, you've all experienced this. If you have a late night, you have some alcohol, you're more likely to snore that night. Alcohol is a muscle relaxant. Smoking will cause edema in the upper pharyngeal space, therefore closing down the lumen over time. That itself can be a modified risk factor. We know there's things where people on their back will snore more, people in the back will have more apnea. Well, gravity, once again, is going to drop the tongue back. So staying off your back might be a modifiable risk factor that one could implement. And the nose is extremely important. We underappreciate the nose. The nose is where breathing needs to take place from. We do know from papers that have been published that oral breather increases the incidence of apnea. If you think about that for a minute, when your lips are apart and your jaw's prone open a tad, you're going to rotate more posteriorly, taking the tongue base more towards the airway. So having nasal breathing be patent is very important. And this is where, an ENT consult of some sort would be extremely valuable. But things that you can modify is your gender, menopause status, which we'll talk briefly on, craniofacial abnormalities, which is what we see clinically day in and day out, genetic. If mom, dad have it, there's a good likelihood the child may have it, but this can also play in the reverse form. Sometimes children get diagnosed. And if children get diagnosed with apnea, then we need to look up to the parents and say, all right, which one of you two may potentially have this? Some races can also have an increased incidence of having apnea, and this is not modifiable. We talk about more of the concavity midface deficiency race, right? And then aging. The problem with aging is as we get older, we lose muscle tone. As a consequence of losing muscle tone, we are more than likely going to collapse. So that's one variable we can't extremely control. Overweight and obesity, as you can see in all these references, there's an extreme number of papers that have kind of correlated the two. So having a conversation about losing weight, especially for those that are obese or morbidly obese, using a BMI algorithm, is extremely important to kind of have that conversation with our patient, explain to them the correlation between weight and airway. Now, there are some things to say why men are more likely to have apnea compared to females. And typically, what we think it leads to is the upper airway shape, the craniofacial morphology of men versus females, and the distribution of fat in males versus females, which therefore makes them at a higher risk. We talked about menopause status a second ago, but what's interesting with menopause is when female actually go into menopause, the risk of apnea increases, almost close to 1-to-1 compared to male. And the reason for that is estrogen is an airway protector. And as you lose estrogen over time, you lose the protective role of estrogen, thus leading to a high incidence of apnea in females. Now, this is menopause that's due to aging, but you can also have menopause that can be surgically induced, such as a total hysterectomy, which still falls within the same parameters of increased risk in younger females. Genetics, I've kind of already alluded to that. There's a high risk when a family member is diagnosed with apnea. There's a higher chance that you're more than likely to diagnose with apnea as well. As I mentioned about snoring, this is things where we need to educate our patients what the effect of smoke is on the oropharynx, independent of cancer, COPD, and all the other elements that are associated with smoking. We want to talk about the swelling that takes place in the oral mucosal tissue, which can lead to narrowing of the lumen, therefore increasing the risk of this condition. And of course, alcohol, as I already alluded to, it's a dilator, all right? It's a muscle relaxant, and hence, therefore, we need to be mindful as far as educating patients not to have alcohol close to bedtime. Problem with alcohol's half-life, it takes quite a bit for alcohol to leave your body. There's really no right time except afternoon drinking, which is not encouraged. But the point I'm making is, within moderation, probably okay. but still something that we need to be very mindful of, that it does affect the upper airway muscle tone. So now comes the dental things, and we're going to spend a lot of time talking about these things. I won't labor the point one by one, but I want to illustrate the point that there are a lot of things in our wheelhouse that we can identify that may suggest a patient has a sleep breathing disorder. So what you as a dentist can do and should do is start to screen your patients. Now, screening can come in many forms. Having a conversation with your patients, having questionnaires, having a poster on your wall that educates them about apnea and what a dentist role could be. It's endless what one could do. What I'm going to suggest is a couple things. So, in hygiene or your new patient intake form, a couple of these questionnaires, if you just were to insert them, can give you at least a starting talking point. But I'm going to point out some pros and cons associated with some of these questionnaires. So the one you always want to have, regardless of how you interpret this questionnaire, is the upward sleepiness scale. When it comes to the point of you providing services for your patients and you are submitting claims to insurance carrier, one of the pieces of information they want to have from you is, do you have an upward sleepiness scale questionnaire in your records? And this is basically eight things of daily living or 8 situations of life, and you score the likelihood of you dozing off from 0 being never and 3 being high chance, right? And as you tally up these scores, the key number you need to target or patients should have to suggest that they have some form of sleepiness, therefore conclude they may have fatigue, is more than 11. Right? Anything less than 11 would suggest it's not a factor. Anything more than 11 would suggest it's something that we need to talk about. But if you take this point into consideration for just a moment, and we rewind to many slides before, and I told you that only 4% of men, 2% of females will actually complain of being fatigued or tired. You're only going to get 4% of men, 2% of females. They're more than likely going to score more than 11 on this questionnaire. And the vast majority might score less than 11, which means if I use this number as a hard and fast rule, I'm going to miss a lot of these patients. But yet I get it filled for record keeping, but I may take the information I get from it with a pinch of salt. Okay. The one I probably would lean more towards is a stop questionnaire. So the stop question is quite straightforward. You can ask these questions to your patients. S, do you snore? T, are you tired? O, has anybody observed that you actually stop breathing during sleep? And P, which is, do you have hypertension? And you probably can pull that from the health history records. 2 or more yeses to the stop questionnaire, the more likely they're mild to moderate apnea when they get tested. All right, it's just to give you an idea of how likelihood of you picking up patients would be by asking the stop questionnaire. There's an expanded version of it called the BANG. The BANG goes body mass index above 35, and you should have charts or you should have BMI little charts for your patients to try and tell you what their weight and height is, so you can calculate what the body mass index is, or you can go online and plug in these 2 values and get a BMI score. Age over the age of 50, neck circumference for males over 17 inches, females over 16 inches, and gender, being a male. The more yeses to the BANG portion, in addition to the stop, the more the likelihood you'll probably test moderate to severe when asked. So you got 8 simple questions you could implement immediately. Few you don't even have to ask, right? For example, age you don't have to ask. You look at the health record sheet. Hypertension, look at the medical history form. Neck circumference, you may have to ask them what's your collar size. Gender, of course, by looking at them. The other piece of information will be, do you snore? Are you tired? Has anybody observed that you stop breathing? And you might need to get a height and weight to calculate BMI. All right, so quite easy, quite straightforward, one simple page questionnaire that you can use every 6 months when they come in for a recall, or implement it into a new patient intake sheet, however you please to do it. But if you already have established practice, you may need to bring this paperwork on a recall system kind of basis. The other is this one here called the Berlin questionnaire. It is quite sensitive to identify patients that have apnea. It might be a little bit of a complicated form to navigate, so I'm just going to walk through this. There's 3 categories. So category 1 is this box here from questions number 2 to 6. And within that, you've got sub boxes that have boxes. For example, do you snore has yes, and then it has a box around it. And your snoring is louder than talking, very loud, there's a box around it, and so forth. In category 1, if they check 2 sub boxes, then when you go to the bottom, which says category 1, which I'll come to in a second, you would check that box that says from questions 2 to 6, 2 of those boxes were checked yes among that little sub classification. You then go to questions number 7 through 9, and the same thing, if 2 out of these 3 boxes are checked, all right, you're going to go ahead and come here to the bottom and check category 2 box. And if you see this, hypertension is a standalone question. It's a yes or no, don't know. But But if it's a yes, it's got its own checkbox, all right? And what you're doing is when you come to the bottom here, as I said, category 1, if 2 of those positive responses are present, you check box 2 to 6. Category 2, 7 through 9, of course, and then of course category number 3, okay? Now, when you take this into consideration, if 2 out of the 3 categories have been checked off, there's a high likelihood that they're going to actually test positive for sleep breathing disorder. All right, so this is another simple question that one could utilize to determine whether there is a high likelihood of having this condition. Basic questions could be asked. That's just to generate some form of rapport, but you really lose guidance as far as what you're getting out of you, and you may end up just, dabbling on these questions, not really getting something on paper to reflect back on as you progress. But there again, do you snore is a question of you stop bang. Are you frequently tired is a question from your stop bang. Are you aware that you're being stop breathing? Once again, these are questions you kind of have asked in the stop bang. So you can just have a systematic way of actually asking these questions. But another thing, interesting enough, is your medical history questionnaire. There's a lot of questions we ask for many reasons. Are you diabetic? We think about healing. Do you have hypertension? Maybe we think about, is it controlled, or do we avoid epinephrine? There's reasons we ask these questions, but there's more we can get out of it if we understand the connection or the likelihood of having sleep breathing disorders with congestive heart failure. So if someone said, I have had congestive heart failure, then there's a 60% chance they're going to test positive for apnea. If they had a stroke or a transient ischemic attack, up to 70% of those patients will actually test positive. If you type 2 diabetic, 65%. Drug resistant hypertension, which means 2 or more blood pressure medications to control the blood pressure, there's an 83% chance they're going to test positive for apnea. Hypertension by itself is 37%, and coronary artery disease is 30%. Now, I'm going to take some of the stuff away from you just so that it's not as busy, and we're going to look at it from another perspective. How many times a day in your health intake sheet do you have hypertensive and diabetes in the check? In other words, patients have hypertension and diabetes simultaneously, but no one's asked the sleep questionnaire, right? This itself can be a subset patient population that you can get educated, get diagnosed, and hopefully, if they do test positive, be in a position to manage the condition to lessen the burden of these systemic diseases, all right? But dentally, we have zones that we can play with, right? Maxilla has a lot of clues, right? The soft palate will give you clues. Teeth will give you clues. Tongue will give you clues. And interesting enough, any bony depositions that may take place may give you clues. So we're going to spend some time exploring these 5 different zones, because this is what we're looking at every day when we look at our patients. But before we get there, we need to look at extraoral exams, right? We need to understand a few factors here. For you to have an airway that's going to collapse, there's got to be a few things on the table. Well, the few things on the table will be skeletal factors, right? Craniofacial underdevelopment, things along those lines. Soft tissue, excessive tissue, a large tongue, large adenoids, a large soft palate, right? Of course, male gender, as I alluded to, more likely until menopause kicks in, then some 1-to-1. And of course, weight that we've been laboring the point on. So if we go to this for just a second and we split up the skull, you'll see that the maxilla, which is what we deal with every day, has clues. If you have an underdeveloped maxilla, then you have to make the assumption that the nasal floor is going to be underdeveloped, because the nasal floor is your maxilla. What I want you to take out of this as well is the inferior border of your orbit is the maxilla as well. And just take that for what it's worth, and I'll explain to you in a second why I want you to be very mindful of this little skeletal presentation that we should be very aware of. I already made the comment that we need skeletal and we need soft tissue, right? As one of those risk factors for facilitating a collapsed airway. So Suno and their group in Japan looked at this, and they kind of published a paper trying to look at some of the factors that may affect or influence airways. So they say that, listen, if you have enough soft tissue, but not excessive, and craniofacially your bone has grown effectively, so your maxillomandible has a beautiful arch shape and so forth, and we superimpose the soft tissue along the bony enclosures, we should have a decent sized airway. Yeah, makes sense, right? But then you have these variations that can present. Someone that's overweight, craniofacially are developed well, but the excessive tissue now creates a compromised airway. Or the flip side, BMI not substantial, craniofacially underdeveloped, tissue looks too much for the bony enclosure, once again leading to a compromised airway. And the sad thing in today's world, unfortunately, is this dilemma we're running into. And Isuno did not look at this back in his time, is in pediatrics, we have kids that are overweight, kids that are craniofacially underdeveloped, and now you got to ask the question, what does their airway look like, right? So just be mindful that we need to try to be a little bit more understanding of where we are presently, based on where some of these papers were published at some point in time, and revisit some of these scenarios. The other thing I want you to be aware of is this phenomenon called nasal cycling. I'll explain to you why in a second, but nasal cycling is you breathe through one nostril for a period of time, and then you cycle and use the other nostril. You never use the same nostril at any one. Let me phrase it. You don't use both nostrils at any one point in time. It's one or the other. There are some variations from this rule, but the phenomenon itself is called nasal cycling, all right? Why I want you to understand this is when we look at this lovely patient right here. So when we look at this lovely patient right here, we look at a couple of things, right? So first of all, if you looked at her orbit on her right side, you'll see that it's slightly inferior to her left, suggesting there's something wrong with the right maxilla. When you look inside the mouth, you'll see that the right portion of her maxilla is not as flared out as the left portion. If we look at the occlusal table for a minute and drop a line to the midline from the mesiolingual cusp of tooth number 3 and then one from number 14, you can see that the right side, that width is much smaller than the width on the opposite side, suggesting a unilateral, probably underdeveloped maxilla. And in this lovely lady's case, we got a study. Now, we didn't study her because she was complaining of tired. She's not overweight. She was much younger at the time. And there's no reason to justify why we needed the study, but clinically, those things to suggest that she may not be breathing well. Well, the study comes back, and these studies back in those days were done with polysomnogram. She tested as having apnea hypopnea index of 12.4. So this apnea hypopnea index is a scoring system that's utilized in medicine to determine the level of severity of this condition. I will say that the severity does not always equate to symptoms that a patient may present with, and severity may not always equate to detrimental to systemic health. The portion there that plays a role is something called the hypoxic or the hypoxic burden, which is how low does your oxygen level get below 90 and how long does it stay there, that will have a consequence on the cardiovascular system and so forth. But just to kind of bring everybody up to speed, when we look at that score, the AHI, A is apnea. As I told you a second ago, apnea means you got to stop breathing for 10 seconds and a few things have to happen. You have to have a change in oxygen levels of 3% when it comes to insurance or 4% when it comes to Medicare guidelines. And you have to have some form of a brain arousal. So if you meet these characteristics and parameters, then this is considered one event. Then the word hypopnea is this. Now, apnea is a 90% or greater reduction in airflow, not necessarily 100, but 90% or greater reduction in airflow meeting this criteria. Hypopnea is a 30% or greater reduction in airflow for 10 seconds, leading to a 3% oxygen desaturation and or a brain arousal where the brain wakes up. Now, when the brain wakes up does not equate to you physically waking up, but when the brain keeps on waking up, we call this fragmented sleep. And these are these patients that feel that they were in bed for a long enough time, but wake up feeling tired because the brain never got through the various stages of sleep that allows them to restore themselves. So that's how that number AHI is composed. Total number of apnea that night, total number of hypopnea that night, and then divide that by the total amount of time you slept to give you an index. So the AHI index, all right? You can see that it's also broken down where in REM sleep, it can be measured that in this case, the REM sleep apnea was much greater, which makes sense because when you're in REM sleep, you're much more atonic than in the other stages of sleep. And on your back, this person had an apnea score of 14.5, but not on their back was 10.5. So you can see that, all right, positional therapy of some sort, keeping them off their back may be beneficial. In her case, her lowest oxygen level she went to was 90%, not bad. So with her, looking at these parameters, we get the study done. And what my worry was with her is the craniofacial underdevelopment here on the right-hand side, the orbit. Now, it's not a hard and fast rule, but when you look at your patients, just look at the eyes, see is one orbit lower than the other. And all it says it could be an underdeveloped maxilla. You got to go inside the mouth and look at the rest, right? In this guy's case, you'll see his left eye looks a bit lower than his right eye. And when you look inside his mouth, you can see he has a unilateral crossbite on his left. And when you study this guy, his apnea hypopnea index is 47. Now, I told you that this AHI represents the severity of this condition. So 0 to 5 is healthy. We don't consider this as a problem, all right? Or I should say 0 to 4.9. 5 to 15 is considered mild apnea. 16 to 30 is considered moderate apnea. Anything above 30 is considered severe apnea. But as I tied into this, Just because the numbers are higher does not mean the symptoms are going to be worse. You can have a severe apnea that does not complain of being tired, and you can have a mild apnea that you can't even get out of bed. Right? So extremely subjective. This guy's case, if you look at this, when on his back, his apnea goes to 74, but on his side, it's only down to 17.7, and his oxygen level goes to a low of 83%. The last number on the right, the hypoxic burden, suggests that for TST, which is total sleep time, he was below 90%, 0.4% of the time he slept, right? So maybe not as significant, even though the number looks bad, like 83, but he wasn't there long enough, right? So these are things I want you to just extrapolate when you look at studies and so forth. So what I was alluding to there is craniofacial underdevelopment. By looking at the patients, you can kind of get a sense, is the maxilla potentially undeveloped based on the orbit? So just things to kind of be very mindful of, but you always want to tie that in with more data. In this case, look at the mouth and see, is there anything to suggest it? The airway evaluation, things that we do every day, can also give you a lot of clues. So look at the top left picture, that's tonsil tissue. Lower left is things you see every day, the scalloped tongue. And on the right side, you see the soft palate, right? You can see slightly red, edematous. It may have a little bit of a drape to it. And you can see the uvula looks edematous. And we'll talk about a few of these things here in a second. Now, when you look at tonsils, there's a classification system that's utilized that you should keep for your note keeping as well. And I'm going to go over what this classification system is. So if they have no tonsils, tonsils are removed, we call that a grade 0. If they have grade 1, 2, 3, 4, the way you determine the grade, you split the midline, right? Split the uvula in half and look at how much tonsil tissue they have from the lateral wall to the midline. If it's less than 25% of tissue, we call that grade 1. If it's 50% grade 2, at 75%, we call that grade 3. And if it's at midline, we call that grade 4. Do also be mindful that it does not have to be symmetrical. You can have a grade 2 on one side and a grade 3 on the other side. But there's a significant discrepancy on tonsil size, like a grade 1 on one and a grade 4 on the other, you need to be worried. All right. In that case, you want to basically think of worst case scenario, and you start thinking things like, oh, nasopharyngeal carcinoma. All right. When you see this type of big variance, and this is referral directly to ear, nose, and throat, just to make sure that you are not missing anything. So once again, tonsils have a classification system. So if you look at these tonsils here for a second, you can kind of get a sense that they occupy a lot of the posterior airway space. If you've got a big tongue, you've got tonsils in the back, you've got very little room for air to passage through when the person's on their back or on their side. So this is why we need to look at tonsil tissue and kind of get an assessment how big they might be. The other thing is tongue level. Just have them open the mouth and say nothing to them. If the top of the tongue is below the occlusal plane, we call that a low. At is medium. If it's above, we call that high. More towards the high, that's too much tongue for the mouth, right? When you lose muscle tone, you're more than likely going to collapse. There's not enough width for you to park itself in the oropharynx. So there's only one place you can go, and that's towards the back of your throat, which may contribute to apnea. Another thing is a thing called the malapatic classification. There's a couple ways to do it. The way I'm going to talk about it is you just have them open the mouth, stick the tongue out. Now, when they do this, you should be able to see the oropharynx. If you can see the entire oropharynx, we call that class 1. If the base of the tongue is at the uvula, we call that class 2. If the base of the tongue is at the soft palate, we call that class 3. And if it's at the hard palate, we call that a class 4, right? Now, what's been shown that if you have a malapatic classification 3 or a 4, the odds ratio of apnea actually increases. So for a class 3 malapatic, it's a 5 times likelihood you're going to test positive for apnea, and a class 4 is about 7.5 times, which is why it's important to look at this. But guess what, guys? You do this every day anyway when you do your oral cancer screening. Don't you have them stick their tongue out to look at the lateral borders? So just look at the dorsal aspect of it and get a sense, is there anything that I'm missing? Okay, so just to create a quick video of what this might look like chairside, a hygienist can do this, you can do this, have them open wide, look at the tongue level, doesn't take a second, right? Go ahead and look at the malapatic classification when they have their stick the tongue out, and then follow through and do your oral cancer screening. And then for tonsils, you want to maybe put your finger back there or put a mirror back there just to create a slight gag reflex. The soft palate rises so you can score the tonsils. And you're pretty much done in less than 10 seconds. You got as much information as you can to look for patients that might be susceptible to having this condition. Now, the other things when I talk to you about the soft palate is looking at it, right? So you can see the top left picture. It's very swollen. It's edematous. Bottom left, you can't even see the oropharynx. We call it a soft palate drape, where it drapes into the airway. Top right picture, you can see the tonsil tissue. And once again, on the bottom right, you can kind of see the scalloped tongue, right? So scalloping is another thing you see every day. And scalloping has been looked at from many different perspectives, but the few things I'm going to shed light on is this. So these were groups of patients that had scalloped tongues. 25 of them were sent off to a sleep laboratory, and 88% of them tested positive for apnea purely on the merit of tongue scalloping, suggesting that scalloping itself is a good risk factor indicator, and with the history of possibly snoring, that the person may have some form of a sleep breathing disorder. It says that the evidence of lack of tongue space comes from examining the clinical features of the tongue. For example, scalloping the tongue is associated with an undeveloped dental arches and therefore possibly the likelihood of obstructive sleep apnea. Right, by Dave Singh in his textbook, writes it really well, but you will see this day in and day out. So scalloping is a feature, suggesting the tongue is too big for the arches. And remember, you've seen these patients when they're upright, they've got muscle tone, nothing's going to collapse their breathing. The question is, what happens to them when they go to sleep? Now, you may or may not know this, but the tongue itself has fat cells in it, right? So that's interesting. So there's this nice, amazing autopsy of tongues that were done, and it's published in Laryngoscope looking at mass, BMI, and a few other factors. And what they found was some interesting observations I want to share with you. First of all, the body mass index had a proportionate linear relationship to the weight of the tongue. Right? So this is interesting. Your weight, your body mass increases, the weight of your tongue increases. Fine. The other thing that they found was also is the distribution of fat. There was more fat on the posterior aspect than the anterior tip of your tongue. Right? So this is important as well. And once again, linear relationship with body mass index. So we do know that the posterior third of your tongue has quite a bit of fat distribution. The problem with the posterior part of your tongue, that's the anterior wall of the airway. So if you put on weight, as shown, your BMI increases, your tongue size will also increase as a response, making your airway more compromised. There's MRI studies done as well looking at this, showing a very similar correlation that the vast majority of the tongue is on the posterior inferior aspect of the tongue itself. And once again, as body mass index increases, the volume of fat cells will increase, therefore closing or constricting off of the oropharynx. So just be mindful how fat can play a big role when it comes to not just body mass, but you can also say in some degree tongue mass. All right, torides, right? So what's up with torides? We see this day in and day out. The jury's out, but there's some thoughts about it. Same thing with exostosis. Does this mean anything to us? Well, when you look at patients and you get them tested purely on torides, it's funny, they do test positive, but there may be other multiple variables as well that we need to take into consideration. And when we do know that the exact etiology is questionable, we do understand that you got to have the genetic presence for it, and you have to have some form of force on it, right? And then the travelers of time. When you take all this into consideration, you're more than likely in some subset patient populations to develop a toride. There's also been looked at anthropological studies where they found wear on teeth, and corresponding to the area of wear on teeth, there was evidence of torus in torus formation, suggesting that the force may be a bearing or a vector to trying or to be part of a precursor in forming excessive bone deposition that may be protective in nature. We don't know completely, but we do see a high connection and correlation with it. So in this paper right here, they looked at risk factors, kind of all the things we talked about, showing statistical significance with hypertension, diabetes, neck circumference, body mass index, large tongue, malapathic classification of 4, and all the beautiful things we talked about. But in this paper, there was also one more thing that they looked at as torides. And when they did the statistics using a different method, multivariant logistic regression, they found something interesting that any toride greater than 2 centimeters increased the risk of potentially having apnea. The problem in this paper is that 2 centimeters, they didn't define the dimension change. Is it anterior posterior? Is it superior inferior? Is it medial laterally? Right? So there was a couple things that still be questionable about this, but it leans towards the fact that if there's a toride, there might be a little bit of a higher prevalence of having this. Now, this next few things I'm going to share with you is totally anecdotal that I see in my practice. I see this over and over again. I just don't understand it, nor have I looked at it by publishing a paper, but here's my anecdotal approach. What I find with patient torides is on their back, the apnea is always worse than on their side. Same toride, tongue position being different, right? So on their back, in this guy's case, 11.6, on their side, 4.6. Look at these torides right here, not significantly bigger than the other, but the same kind of contrast. On their back, 47.1, on their side, 4.4. And in this case right here, on the back, 20.1 apneic score, and on their side, 1.4. Now, once again, I think that maybe the fact that you have this toride that's there, there's not enough room for the tongue to fall back into, hence, therefore, it cannot go to the floor of your mouth, and therefore, it probably slides or regresses back into the airway. my speculation, but more of my clinical observation that I want you to be mindful of. All right, so tourize is potentially another risk factor that we need to keep at the back of our mind, taking up tongue space, but maybe generated as a result of a few factors that we'll talk about here in a second. That's a good legway into this. Non-carious cervical lesions, right? NCCLs, abfractions. So abfractions, once again, a debated topic. I think the understanding is that, yes, you have to have some form of forces on these teeth, and that's the most weakest junction of your CEJ, hence therefore the hydroxyapatite crystals for the enamels are chipping away, leading into the cervical lesions that develop, right? So we've seen various papers that kind of talk about it, but there's also papers that kind of disprove this. I just want you to be on the lookout that this whole abfraction consensus is pretty controversial, but I want to shed the light of what we know from a sleep perspective. All right, so this has been looked at, as I mentioned, the non-carious cervical lesions is due to force. Now we have to ask the question, what's driving the force, right? So we know parafunction's a factor. Hey, we all get it. We see this day in and day out. It's worn down teeth, fracture restorations, and in this case, maybe cervical abfractions, but what might be driving it? So there's two amazing papers that came out of the University of Virginia. This is one published in 1991 where they looked at a couple things. They took healthy individuals, and what they did is put EMG leads in the master and the genioglossus. And this first set of experiments, they put a mask on these patients and had them breathe oxygen. And as they were breathing O2, they would slow down the O2 and increase CO2s. And they found an interesting linear relationship once again. As CO2 concentrations increased, the strength of contraction of the elevated muscles also increased. And then what they found was that the masseteric muscle activation was seen soon after the genioglossus muscle fired. Right, so you have the genioglossus muscle fired, and thereafter, soon after, the master muscle fired. And what they think is the understanding or explanation for this is that the activation of the master muscle serves to stabilize the mandible and allow the genioglossus muscle to function as a more efficient dilator. Since the genioglossus attaches to the symphysis of your mandible, for it to move forward, you got to lock the mandible down. But to lock the mandible down, you got to hit the elevator muscles. Even though they looked at masseter, I'm sure the temporals fired off because you cannot fire master without the temporals or the medial pterygoid. Point being is they found this interesting observation that as CO2 levels increased, you had mastery muscle activity. Same group of researchers, a different year, same kind of an idea, same kind of a setup. But this time what they did is they put a mask on, they put the leads on, as I mentioned, master and genioglossus. But what they did here is the person's breathing, and they just slowed down the breathing. In other words, they created inspiratory resistance by stopping airflow. And they saw a very similar response, right? So can it be that possibly in some of these patients, some of these lesions may be due to the fact that they stopped breathing for a period of time, and possibly for them to open up the airway, there's going to be some level of force that's going to be sustained on their teeth, which then may lead to cervical abfractions and or torize or exostosis formation. All right, this is not across the board. So I want you to be mindful that when you see this in your patients, don't say this is why it's happening. It's a situation where this could be contributory to why you have these lesions, why you have these torides. But the only way to be for certain is to get a test done and see whether you do or don't have apnea. And also, when you look at the data in the apneic patient population, not all apneics brux. All right, so keep that in the back of your mind. There's just too many moving parts here. But the fact is that we need to try and look at it and say, could it potentially play a role in your case? The other is GERD, okay? When you have lingual erosions, and we know there's a high correlation with GERD and obstructive sleep apnea as well. There's a lot of theories of why this might be so, but at the end of the day, when you see patients with lingual erosions or occlusal erosions on the lower molars, I'm going to ask a history of acid reflux. And there's no way to justify why they have acid reflux. For instance, not eating a late meal. They don't have gastroesophageal sphincter issues. They've been scoped. There's no explanation for it. Could it be that apnea is maybe driving this, right? So there again, something to keep in the back of your mind when you see this type of observation. If you look at this gentleman right here, you can see wear on his teeth, you can see exostosis, you take his history, he goes, man, I have hypertension, I have heart disease, I have GERD, I have anxiety, I've been told that I kicked in my sleep, I've been told I snore, I've been told that I stop breathing at night, I do have mild depressive mood, I have mild memory impairment, and this is a male patient, all right? So we say, listen, sir, I think the best thing for you to do is let's just get a sleep study, try to look at the bigger picture here. Gets a study done, you kind of get a sense of this gentleman right here has severe apnea, AHR 42. On his back, it goes up to 63, and on his side, it's down to 31. Yes, his oxygen burden is not significant, it's about 0.9% of total sleep time, but still relevant enough that he desats to a low of 88%. All right. So this guy here, same situation. However, when you look at his story, he does have GERD, he has depression, he has anxiety. He's been diagnosed with having sleep apnea. He wears a CPAP or had a CPAP. There was only 7 centimeters of water pressure, found it too cumbersome. He was claustrophobic. He discontinued the wear. Get a sleep study, you look at the numbers. All right, so you're severe apneic, 36.8. On your back, you're 32. On your side, you're 72. And yes, I get this question asked, why is there a big discrepancy between side, in this case, and back, which maybe it's the other way? You then have to go back to the recording time and see how much of their time they spend on their back versus their side. In this guy's case, he spent more time on his side than his back because of a back injury, right? So therefore, that number will get skewed. But what's interesting with him is he descends to 77. We get that. But if you look at his hypoxic burden, it's 61.5%, which means more than half the night, his blood oxygen level is below 90%. Now, that is cardiovascular mortality here, or morbidity here. By educating what that number meant, it's easy for me to get him back on his CPAP. I was not comfortable putting him in oral appliance because I don't think I can change the hypoxic burden as significant as it was. But when you explain to him, sad to say, I did say, it's almost like you're a dead man walking, sir. Boy, CPAP compliance improved. He's a machine. I've not seen him back. All right, so you got to look at this data. You got to look at these numbers and understand what do those numbers say. But what I want to tie that into is GERD is quite prevalent. All right, 3 out of 4 patients routinely with sleep-related issues will wake up because of acid reflux-like symptoms. We need to take GERD into perspective. Remember, you're looking at it from another perspective. You have patients that have a history of GERD, taking Prilosec and all these acid suppressors, but maybe no one's taken a sleep history. Maybe no one's explored that is probably sleep playing a role here. Now, I was sidewinder a little bit and talk about craniofacial underdeveloped. And a good example is this paper right here, where they looked at adolescents. And these were adolescents that were class 2 malocclusions, right? And what they did with these patients is got a baseline sleep study prior to the onset of orthodontics. But the orthodontic intervention they did was palatal expansion and bring the mandible forward. And then they follow these kids for a period of time. So not to label the data here, but you'll see that majority of class 2 malocclusion is the mandible is back, right? So when you look at what they call SNA angles, which is where's air point, which is where's the maxilla to your cranium base, and where is B point, your mandible to your cranial base, these numbers, SNA and SNB is what's derived. You'll find that with most class 2 malocclusions, B point is more posterior, suggests the mandible is retruded. So therefore, it makes logical sense that if you see these children, you want to maybe expand the maxilla so the mandible is not trapped, and then bring the mandible forward, right? As opposed to, not saying that there's not a time and place for it, but as opposed to maybe taking 4 bicuspids out and taking everything back when everything's already back, right? So just something to think about. So as you can see, before and after, you've got some data points here. And you can see that the after B point improved from 74.7 degrees to 77.3. You also will find that the posterior space that was measured went from 10.1 to 13.3. This is great. But what's even better, if you look at baseline sleep study data, showed a respiratory disturbance index of 7.3. And post-treatment, 12 months, was down to 1.3, purely by just expanding the maxilla and bringing the mandible forward. So once again, we do know that some of the risk factors for apneics is retroclined mandibles, right? Deep bites, retrognathic mandibles. These are patients that are high risk. If the jaw's back, the tongue's back, all the things we talked about a second ago. All right, so there again, deep bites, retrognathic mandibles, another risk factor. Amma Johal, a friend of mine in London, he did this paper here. Same thing with him. He found that vaulted palates was a risk factor for apneics. But that also makes sense because remember, if the maxilla is underdeveloped, which means laterally it's not developed appropriately, which is one of the bony reasons for apnea, you're going to have a vaulted palate. And if the maxilla is underdeveloped and you have a vaulted palate, then you know the nasal floor is also going to be underdeveloped, especially from a width perspective, right? Therefore, increase the likelihood that these patients will be mouth breathers. All right, so when you look at palates like this, these are risk factors. So this guy's 25 years of age, BMI 25, right? So he's not overweight. He's a young kid. He's got a vaulted palate, but you get this guy tested and you can see that he's got moderate apnea at 24.7. However, on his back, it's 67, severe. DSAT not too significant in this age, therefore it probably has good muscle tone, but once again, a risk factor. So something that you want to keep in the back of your mind. Bruxism is very controversial when it comes to the space, but what I want to tie in with bruxism, just a few observations that have been out there. often a component of a TMD disorder, and maybe related to, of course, bruxism. But of course, do understand that TMD is multifactorial. It's not just one reason why people have it. But what you'll find is that most people have apnea that's worse on their back. And Okerson has published 3 different papers looking at the same thing, finding a very similar observation that most people will brux more on their back versus their side. All right. So could there be an overlap between what we see with airway being influenced on your back and what bruxism influences on your back? Now, this group right here, Smith and them out of Johns Hopkins, did an interesting research paper. They took a series of 52 patients coming into a pain clinic that presented with the classic signs and symptoms of TMD when worked up. But what they opted to do is not treat them, but put them all in a sleep lab. So they put them in a sleep lab, get a full 9 polysomnogram, pull the data and try and look at this data. And what they found that 43% of these patients, you can say roughly half, had 2 forms of a sleep issue. One was apnea, the other was insomnia, right? Suggesting that some of the high incidence of patients with TMD may also have an underlying airway instability that may potentially contribute to it. The Simmons and Fern out of Houston did something interesting. They looked at a couple of things related to bruxism and said, you know what, could it be, and this is where dentists have a hard time digesting the statement I'm going to make, that can it be that noctism bruxism may be a compensatory mechanism of the upper airway? A compensatory mechanism. Bruxism may help overcome upper airway obstruction by activation, the clenching muscles, which are your elevated muscles, which results in bringing the mandible, which is your genioglottal, forward, and therefore opening up the airway. Could it be more of a protective role than what we consider feel more of a pathological role, right? Yes, it destroys our dentition and all that good stuff. Yes, patients may come in with pain, but could it be protective in nature? And I do like the statement because if you think about this and mull this over for a minute, maybe bruxism is not a bad thing. Maybe it's a protective thing, and we need to just explore this further. Now, with that being said, you're going to have reps come up to you and say, hey, you need to buy a CBCT so you can assess the upper airway and all the good things that come with buying a CBCT. And there's papers to show that, listen, when you look at smallest area between obstructive sleep apnea patients and non-obstructive sleep apnea patients, you're going to see increases in area in the healthy subjects, less area in obstructive patients, right? And there's these correlations and publications that have been made to kind of suggest that. And then they may show illustrations show this is a compromised airway, image number C and D, whereas image number A and B is a nice patent airway. Yes, and all this is beautiful when you look at it from this standpoint. All right, now, if you look at volumes and you look at volumetrically and you look at the oropharyngeal space and you try and get a sense, okay, can I predict who has apnea? And I'm giving you this data set. Minimum area was 84, 59, and 186. You might all lean towards picture number 2 or the middle picture. Oh, it's a small airway. But when you get the sleep study on these airways, it's interesting. Patient number 1 here, RDF 22. RDF means respiratory disturbance index, which is the apnea hypopnea index that I've already told you, and something called RERAS. RERAS basically stands for respiratory effort related arousals. So it's a situation where they don't meet the criteria for apnea, they don't meet the criteria for hypopnea, but there's still a change that occurs that wakes up the brain. So when you put that into consideration, you have a new index called the RDI, but still suggesting some disruption between airway and brain. Picture number 2, which is what most people will pick, yeah, patient has an AHO 21.9, kind of predicted that. But this guy here at the end, which is a massive airway, come on, he shouldn't have apnea, but has it at 13.3. What you don't see here is we don't know how the airway behaves when the person goes to sleep. Remember, most imaging is done upright, and of course you're awake. If you're awake, you're going to guard your airway. You're going to have muscle tone. But there's not quantified that this means that the airway is going to be worse when someone sleeps, right? I would have thought that picture number 3 with the amazing minimum cross with amazing minimum area of 186 is not going to collapse, but it did collapse, right? So we got to be mindful how we take imaging into consideration. Dr. Danya Tamimi, that reads for Beam Readers, amazing textbook she's got on the topic of dental radiology. This is her slide, and she's also trying to illustrate this point. That listen, just how you cock the head in the machine influences minimum cross-sectional area and volume. And this is her scans. She took 2 images on herself to illustrate this point. Right? Because we don't have standardization of how do we put a patient in a machine if we're going to use this type of data. Even though Beam readers will write this in their report, they write this because us dentists want this. But we got to be mindful, what does this really mean? So just my 2 cents on it. All right. Now, how do we take all this into consideration? Well, if you do restoration and restorative dentistry and things break, you start asking questions. But why don't we ask a question from another standpoint? What was this person's Epworth Sleepiness Scale? What is this person's body mass index? Is this person a snorer? Is there any scalloping in this tongue? Is there any craniofacial underdeveloped in this patient? And could it be that parafunction drove this, right? And if it is parafunction, then okay, I'm going to restore your teeth and I'm going to put you in a night guard. I'm going to put you in a bite guard to protect this comprehensive dentistry you have done by me. Problem with that is we need to understand that by sticking acrylic into someone's mouth, we can influence the airway as well. If you are with me right now, you understand that if the tongue is the culprit and people have craniofacial underdevelopment or large tongue, etc., that by me putting a bite guard in someone's mouth, am I not taking away tongue space? Have I not just made the craniofacial undeveloped mouth even more undeveloped? Because I added more material in their mouth, right? So you got to think it through. And in that case, some of these patients will be at risk, right? And this has been shown that just by giving vertical splints that have some thickness to it, can affect the airway from a negative standpoint, all right? So this is nothing new. It's that we don't ask questions and we don't think it through. I do like to use this example here for one or two reasons, just to illustrate 2 points. So these are images of the velopharynx of a series of patients. The pictures on your far left is just baseline airway. Pictures in the middle is when the jaw has been protruded. Okay, and the pictures on the far right is when it's just vertical given. And you see that with vertical given, there's an adverse effect. 80% of the time, the airway gets compromised, gets minimized. Sometimes it actually improves the airway just by giving vertical, as you can see in the middle section. And about 17% of the time, nothing happens. Okay, and that's when we hopefully get lucky, that the latter two. All right, so about the 20% of the time we get lucky with these patients, they feel better because we get a bite guard, they see they sleep better, amazing, or it makes no significant negative effect 20% of the time. What about the other 80? But if you protruded the jaw in that same subset patient population, then you would have an adverse effect. Just by slightly protruding the jaw, you can see that you make a positive impact on the airway, which is the images in the middle. All right, so keep that in the back of your mind when it comes to using bite guards as well. The type of bite guard you might utilize can influence the airway positively or negatively. So to kind of wrap this up and kind of conclude this, when you look at your patient, start looking at asymmetries. We talked about the maxilla, start looking at the eyes, start seeing if there's anything that would suggest asymmetries for underdevelopment that's taken place. I didn't talk about submandibular space, but like a double chin, things of that increase the risk of potentially having apnea. Look at the nasal passages. A nasal valve that's collapsed, as you can see on the far left image, would suggest more negative resistance when they inhale through that nostril, through nasal cycling. If you have more negative resistance getting air in, you're going to have more interesophageal pressure, which leads to more collapsibility of that airway. So things just to keep in the back of your mind. Retrognathic mandibles that we talked about, neck circumferences, things that you can basically get, of course, body mass index, right? So these are your risk factors that you're going to kind of leverage off of. The other things I kind of talked to you about was the maxilla, looking for asymmetries and underdevelopment, looking at teeth such as abfractions, facets, erosions, looking at soft palates such as the Malapati classification, the 3 and the 4 being a higher risk for having it. I didn't talk about gag reflexes, but if you have a patient that has a gag reflex that's not present, in other words, you get an impression, you get a lot of impression material, and you take this to the doctor, and you're like, hey, listen, is this good enough for a bleaching tray? My first impression was like, is this person on a gag? I mean, they should have a gag reflex for this. You'll find that in aggressive snorers, the gag reflex is actually dampened, okay? Because snoring is a battering effect, and that soft palate is vibrating for decades. You're going to dampen some of the reflexes that are present for gag. This is taking into consideration that don't have a neuromuscular reason for this, all right? Uvula, tonsils, things that we already touched on, tongue scalloping, tongue level malapatification, and then we talked about the whole bone thing there a second ago, torides and exostosis. So things I want you to be very mindful. These are clues looking right back at you. Understand what it is, ask the right questions, and then we'll, make the appropriate referral. As a dentist, we do not diagnose sleep disordered breathing, all right, or apnea for that matter. We need to work with our medical colleagues, and a medical colleague needs to give us a sign off. I know state by state there may be variances to this, being that this is a webinar, it's going to be seen by all sorts of people. You need to look at your state boards and know what your limitations might be in your state when it comes to this space. But best practice, you want to work with a medical colleague. I'm going to finish off with this little plug-in. Myself and Gary DeMargin, a good friend of mine, and 2 other faculty members from UCLA published this book a couple years ago from Springer. I think it's the first official dental sleep medicine textbook, pretty comprehensive. We have a second edition that we've just been sanctioned to write. That'll probably be out in another year, year and a half. So with that, I'm happy to take any questions that anybody might have and go from there.
Wonderful. Thank you, Mayor, for that outstanding presentation. It's certainly a great reminder that as oral health professionals, we're certainly uniquely positioned at the crossroads of airway and oral function, and have both an opportunity and an obligation to serve as frontline defenders, whether it be screening, intervening, and or collaborating to restore not just sleep, but health, longevity, and quality of life. And so thank you for that.
You're
There are
welcome.
some questions
Yeah.
coming in, but before I get to those, I would like to remind everyone to use the Q&A feature in the control pane on your screen to ask any questions. And I will get to the first question here. You mentioned it a little bit in your talk as it relates to just being multidisciplinary and interprofessional, but how can dentists really collaborate more effectively with physicians and sleep specialists and other healthcare providers to ensure patients are receiving comprehensive care? What's worked for you?
Yeah, and this is where it gets tricky, right? So I know we got different cities, we got different specialists and different, like for example, Atlanta, we have a lot of sleep clinics here. Finding a sleep physician is not difficult to do so, but remote Georgia, it is very difficult. So I'll give a couple of resources that are out there. I've been using a physician right now on telemedicine, board certified in multiple states, and the reason for that is access to care. Patients don't have to travel. Today's world, the diagnostics are done using home studies, so you don't have to physically be in a laboratory. So that's a plus. So these are also pluses to educate your patients. They may have family members that went to a facility or a family member that got stuck with a CPAP, and because of that stigma, they are going to outright refuse, I don't want to get tested. But if you can just tell them what the trends are, for instance, testing is on your own bed, you don't have to go to a clinic for an appointment, and your options are not only CPAP, they could also be oral appliances or adjunctive therapy or positional therapy. So let's find out what you have and let's come up with a treatment plan, because what I tell patients point blank, listen, if you have sleep apnea, it's a silent killer, right? You don't know you have it, but you'll find out because you have cardiovascular diseases, you have hypertension, you might get a stroke, something bad will happen, and then you get tested. And we do know this, the correlates with some of these systemic conditions and its attributing factors being apnea. So why not play defensive? Why not go get tested, see what you really have today, and then move forward with it? So I use a company called Sleep, SLIIP.com. It's a play on words, like I said, in multiple states. But I like their whole setup. They take insurance, it's done through telemedicine, and we can get them diagnosed. Prior to these telemedicine companies being around, I would just knock on doors. Sleep physicians are not going to say no to patients. Sleep labs are not going to say no to patients back in the day when we were not doing too much home sleep studies. So I would just call them and let them know, do you have the bandwidth to accept new patients? Was a good way to kind of put the foot in the door. And I'll say, listen, I'm a dentist down the street. I'm screening my patients. I need to get them tested so I know what they have. Are you willing to see my patients? And what this did, it started a rapport. I would send patients their way as a response to it. Here and there, I may get a trickle back, but it allowed me to get into the facility and have a word with the medical directors or the sleep physicians, or the nurse practitioners, and let them know the services I provided. And that's a good way to kind of do best practice. I do know there's HST companies that will have physicians sign off and give you a diagnosis and give you a sleep order. You know, so my only take with that is they have not seen this patient. Everything's based on just data that there was wearables. They don't know anything above and beyond it. I don't think it's wrong. I just think it's got to resonate with your practice philosophy. And personally, I'd rather have these patients seen by a physician and make it their responsibility to manage that condition. So, I mean,
Yeah, you may have alluded to this, but as it relates to the home sleep study or home sleep test versus the old sort of analog polysomnograms and the overnight stays and all the wires and all the stuff in a different and foreign environment. But in your opinion, what's been the most exciting development in this field in your time practicing and researching and studying
yeah.
and caring for people?
So what seems to be more and more popular is wearables. People coming with these rings and these wearables that they say, listen, I was told I desatted, I had fragmented sleep, I'm not sleeping deep sleep. And this is actually bringing a rapport. I had a lady today tell me about the mattress or the bed system she has tells her how active or deactive she was. And she whooped out the little thing and said, look, I'm not sleeping well. What can we do about this kind of a thing? So wearables might be the biggest change that's happening. I do know that Apple Watch had some technology that's going to come back where they could screen for apnea, but it got pulled because of something that Samsung owns. Hopefully this will get rectified, and as a result, Apple Watch will probably be a way of actually testing patients. Why I'm excited about the watch is I can do my titration with it. So if they have the watch and they're wearing an oral appliance, they can just look at the metrics and decide, do we need to advance them or not, prior to me conducting a study for them. So these wearables probably have some good promise in the very, very near future.
Yeah, and titration of mandibular advancement devices is a whole other conversation we could have another time.
We sure
Let me
can.
see let me get one other question in before we looking ahead. This is a good question. Looking ahead, how do you see advances in whether it be technology like the wearables and or AI and this added push from a reimbursement side on medical dental integration sort of shaping the way we screen for, manage, and co-treat sleep breathing disorders?
Yeah, I mean, I know there's a lot on the horizon. I think what I would learn the lure to is when you want to build this relationship with your medical colleagues, you want to be in a position to build medical, right? You do not want to be in a situation where it's a cash kind of a service because there is reimbursement for it. And there's companies one could reach out to that teach you how to bill or can be a partner in billing for you to make access to care and allow these patients to get these devices. The other thing I want to say actually is don't price gouge. I mean, be fair, be market fair. You're saving lives. Patients are extremely grateful. They themselves will build your practice. AI, I think, is the next thing that's coming here or coming in this space. I'm not too well versed in it, but I understand there's things that would probably help us screen for these patients and things along those lines. But as I alluded to a second ago, your health history form, if you just understood what these questions meant, you yourself are basically using some form of intelligence to screen these patients and try and get them to a point of getting them diagnosed, really.
Yeah, it's really interesting. It's sort of going through the history and physical examination with a different mindset and a different lens, not the mindset and lens of a dentist, but
Yeah,
the mindset and lens of an oral health professional who's really focused on improving overall health outcomes, not just dental outcomes.
exactly.
So that's fantastic. Well, I'd like to thank all of you for your questions. We've run out of time for today. If we didn't get to your question, we will answer it after the webinar via email. Within 1 hour, we will send you a link to the recording of this presentation and instructions on how to access the free CE quiz to receive your certificate. But I'd like to thank you again, Mayoor, and thank our sponsor for this webinar, Nexus Dental Systems. To learn more about Nexus and Nexus Bill, one of the medical billing platforms you mentioned, you can please visit nexusdentalsystems.com. Thank you all, and be well.